All right. So up till now, we covered the aerobic bacilli, which had the Listeria, Bacillus, and Corynebacterium. Now we're going to cover the anaerobic bacilli, which include the Clostridium and Cutibacterium, which was formerly known as the Propionobacterium. Now, Clostridium is more important for us, Cutibacterium not so much. Cutibacterium acnes is basically a slow-growing part of your normal flora. It is involved in acne infections. Anyways, we're going to focus on Clostridium because Clostridium is more important for us. Now, Clostridia is basically, as we said, a big picture. It's a gram-positive rod. It is spore-forming. It's an obligate anaerobe, so it does not need oxygen to survive. It's found in soil, dust, human intestine, and animal feces. The two important neurotoxins of Clostridium. Clostridium works through proteases that destroy snare proteins. A protease basically destroys a protein. And what does it destroy? It destroys snare proteins, right? The two important neurotoxins that we're going to talk about here are basically the tetnospasmin and the botulinum toxin. The tetnospasmin causes tetanus, and the botulinum toxin causes botulism. Now, what are snare proteins? Snare proteins are really needed, necessary for neurotransmitter release. Now, at the nerve ending, a vesicle containing the neurotransmitter is supposed to have a membrane. Now, when that membrane fuses with the membrane of the nerve ending, the neurotransmitter is released. What happens in these neurotoxins is basically these snare proteins. What do they do? They allow the vesicle to fuse with the membrane. Right now, if the snare proteins are cut, there's no fusion, there's no neurotransmitter release, and the disease progresses. Right? So, neurotoxins basically cause disease through cutting off the snare proteins and stopping the neurotransmitter from being released. Now, first, let's look at Clostridium tetani, right? So, what happens in Clostridium tetani? This is the picture of the Clostridium. These are spore-forming bacillus rods. They're gram-positive. They're anaerobic. Okay. In Clostridium tetani, what happens is there's tennis racket appearance of these bacilli. Can you look here that these Clostridium tetanus appear such as like the tennis rackets, right? They have a tennis racket appearance on the microscope. Now, these spores basically of the tetanus enter through rusty nails, soil contamination, deep puncture wounds, and burns. That's how the tetanus enters. That's why you always get a tetanus shot when you reach the hospital through a road traffic accident because soil contamination, burns, and rusty nails. That's how these spores basically enter your body, right? The rust, important to remember that the rust itself does not contain tetanus, but the problem is contamination with soil spores. So once the soil gets added to the rusty nails, now it can cause contamination, right? The virulence factor is technospasmin. It is a powerful exotoxin. It blocks the release of GABA and glycine from Renshaw cells in the spinal cord. Normally you have a motor neuron, and that causes the muscle to contract. The Renshaw cells release GABA and glycine, and these inhibit the motor neurons, and the muscle relaxes. Now, this is a normal inhibition mechanism. Normal, Normally this happens in the body, right? What happens in tetanus is this is blocked. I'll show you how. So normally you have a motor neuron, the muscle contracts through, and the Renshaw cell later on, after the muscle has contracted, releases GABA and glycine, and this inhibits the motor neuron and the muscle relaxes. But in tetanus, what you're doing it's blocking the release of GABA and glycine from the Renshaw cells in the spinal cord. The spasmin travels retrograde to the spinal cord. It blocks the release of GABA and glycine from these Renshaw cells, and the result is that you get no inhibition, the motor neurons fire continuously, the muscles remain contracted, and you get spastic paralysis, right? And this will give you basically a trismus, locked jaw, risus sardonicus, raised eyebrow, and open grin, and opisthotonus, basically spasms of spinal extensors. Now, why do you get spastic paralysis? Because the muscles are stuck on. They're constantly on. They're not relaxed. Imagine pressing the accelerator of a car while cutting the brake line. That's tetanus. There's no brake on the muscles, right? Trismus is basically locked jaw. The patient cannot open the mouth. His mouth is locked. The masseter muscle gets like spasmic. It gets spasmed. That's basically trismus. And then rhizus sardonicus is this wide, very creepy grin, like a weird kind of a Batman Joker smile, right? That's rhizus sardonicus. Raised eyebrows are accompanied with it because it's basically a facial muscle spasm. And then opisthotonus is basically the body bending backwards like a bow. And that's because of due to severe contraction of the back extensors. So the body basically bends backwards. I'll show it to you here what opisthotonus is. So this is opisthotonus, right? So the body bends backwards like this weird bow posture. And this is basically Rhisis sardonicus, right? Can you see his eyebrows are raised? His he has this creepy wide grin, right? Okay. Diagnosis is mostly clinical. There's always like a wound and the person is not vaccinated. How do you treat? You basically neutralize the toxin. You prevent with the tetanus vaccine. You treat with an antitoxin. This is basically the human's tetanus anti immunoglobulin, right? And you kill the bacteria using metronidazole. You control the spasms using diazepam. The diazepam is basically for muscle spasm. The antibiotic is most commonly the metronidazole. You treat with the antitoxin, which is basically the human tetanus immunoglobulin. And then also you do wound debridement because you remove the source of the spores, right? Or prevention is through the DPT vaccine, the tetanus toxoid vaccine. We give it to children. Remember that the tetanus basically blocks the GABA and glycine, and that leads to spastic paralysis. We now move on to Clostridium botulinism, right? Now, Clostridium botulinum basically a big picture. It's a gram-positive rod. This is also spore forming, and we know that Clostridium is anaerobic. It produces the most potent toxin known. This is a very, very potent toxin, right? Adults eat the preformed toxin. So when adults get this, they basically eat the preformed toxin. Its common sources include canned foods, preserved foods, and bottled food. And since we're seeing that it's mainly present in bottled food, so you can remember bottled bad bottles give you botulinum, right? Okay, so what happens is classically you eat the spores, and the most in infants, what happens is it's very, very common to eat the spores, and the spores germinate inside the intestine, and this causes the floppy baby syndrome. In Pakistan, it's very common for little infants to get something traditionally called as the gutti. The gutti is when someone in the elderly family gives a little bit of a honey to a newborn infant, and they eat the spores, and the honey spores germinate inside the baby's intestine, and the baby doesn't have the immunity yet to fight off the botulinum, and the baby gets this floppy baby syndrome. The virulence factor is basically the botulinum toxin. It's a heat labile neurotoxin. It normally what okay, so normally the motor neuron releases acetylcholine, right? Acetylcholine release after it's being released, the muscle contracts, and what botulinum toxin does is it destroys the snare proteins. Let me go ahead and show you. So normally, motor neuron releases acetylcholine, right? And acetylcholine basically causes the muscle contraction. What the botulinum toxin does is it destroys the snare proteins, and the result is that there is no acetylcholine release. The muscle cannot contract, and the baby gets flaccid paralysis. What does flaccid paralysis means? Flaccid means muscles are off. Tetanus is basically the accelerator is stuck. The opposite happens in botulism. In botulism, the engine won't start, right? So the muscles are literally off. The baby is floppy. You get descending paralysis. It starts in the face and then it moves downwards, right? Um, and then there are four Ds of this botulism. We call it diplopia, dysarthria, dysphagia, and dyspnea. These are the four Ds of Clostridium botulinum. Now, infant botulism is basically when there's a weak cry, poor feeding, constipation, and a floppy baby. The treatment is basically adults are treated with an antitoxin, right? So, treat with human botulinum immunoglobulin for adults. Um, Botox is something that you guys should know. It's very common nowadays. Botox are small doses of the same bacteria. They're small doses used for wrinkles, hyperhidrosis, dystonia, and muscle spasm. Why? Because it temporarily blocks the acetylcholine release, and your muscles become all these weird, like they just get like stuck in one position. So your jaw, your lips enhance, and so what? You get all this Botox. So remember, botulism blocks acetylcholine release and it leads to plastic paralysis. We will now move on to Clostridium perfringens. This is basically a gram-positive rod. Also, it's anaerobe, spore forming. The important thing about Clostridium perfringens is this alpha toxin. This alpha toxin is basically a lecithinase. And what does the lecithinase basically do? Lecithinase is a phospholipase. So basically, where do you see lecithin in your body? It's the major phospholipid in the cell membranes, right? So this alpha toxin destroys the cell membranes. Since the cell membrane is destroyed, you get cell death, tissue necrosis, and you get gas gangrene. This presents as a soft tissue crepitus and hemolysis. Um, it's important to know that gas gangrene is also called clostridial myonecrosis. Why myonecrosis? Because basically the necrosis of your muscle. The muscle literally dies. The bacteria ferments the tissue and the gas accumulates. You can see a picture here. It's pretty disgusting, but that's literally how it manifests. The clinical clues include severe pain, swelling, black tissue, and crepitus. What is crepitus? Crepitus is basically gas bubbles under the skin. It feels like Rice Krispies bubble wrap kind when touched. The photo in your slide here shows classic gas gangrene, right? Then the other poisoning that the Clostridius does is the Clostridiodise difficile. This is basically spore. Oh, sorry, I'm here. Wait a second. Let me just read this with you. Clostridium perfringens produces alpha toxin lecithinase, a phospholipase. This can cause myonecrosis, a gas gangrene, presents as soft tissue crepitus and hemolysis. If heavily spore contaminated food is cooked but left standing too long at less than 60 degrees Celsius, the spores germinate. You get vegetative bacteria and a heat labile enterotoxin enters the system, and food poisoning symptoms occur in 12 to 12 hours, and resolution happens in 24 hours. So, this is something I'm trying to tell you here. Spores survive cooking, right? If heavily spore contaminated food is cooked, but you left it standing outside at less than 60 degrees Celsius, the spores will basically germinate, right? They will multiply and cause the bacteria. This is vegetative bacteria. And what happens is the spores germinate, they produce the enterotoxin. This is the heat labile enterotoxin. It causes watery diarrhea, it causes abdominal cramps. They usually dissolve in 24 hours. Okay, so what's the treatment for gas gangrene? For gas gangrene, the treatment is surgical debridement. You give penicillin and you give hyperbaric oxygen sometimes. The thing is that since this bacteria survives, it's an anaerobe. It survives without oxygen, so hyperbaric oxygen sometimes helps kill it. Right? Remember that perfringens perforates tissues. This perfringens perforates tissues. Think about gas gangrene whenever you think about perfringens. And now we have the last kind of Clostridium, which is the Clostridiodise difficile. The old name for Clostridiodise difficile was Clostridium difficile. It doesn't matter, just remember it for the sake of remembering it. It's a gram-positive rod, it's anaerobic and it's spore forming. Transmission is usually after antibiotics, especially in clindamycin, ampicillin, cephalosporins, and fluorochlorinins. They're also associated with PPIs, right? They're often secondary to antibiotic use. So you use an antibiotic like clindamycin or ampicillin, and you'll also use a proton pump inhibitor with it, and then you get this Clostridium difficile. So first you're going to take an antibiotics for some reason, and then this infection will manifest itself. Normal situation in a normal human, healthy gut flora suppresses the C. difficile. So C. difficile is part of our healthy gut bacteria. It's part of our gut bacteria. But healthy gut flora basically suppresses the C. difficile. Now, normal flora die and C. difficile grows and toxin production causes colitis, right? After antibiotics. Now, after antibiotics, what happens is the normal flora dies, the C. difficile grows, and toxin is produced. And this leads to colitis. There are two toxins, the enterotoxin and the cytotoxin. The toxin A is basically the enterotoxin, and toxin B is the cytotoxin. Both damage colon epithelial cells, right? I'll just write this here. So both of them damage colon epithelial cells. They cause pseudomembrane colitis. You get watery diarrhea, fever, and abdominal pain. Why there's a pseudomembrane on the colon? You can see the pseudomembrane on the colon. These are basically dead cells and fibrin and inflammatory debris from yellow plaques. Can you see these yellow plaques? These yellow plaques have dead cells, they have fibrin, and they have inflammatory debris. These are basically yellow pseudomembranes, right? You can even see it on the X-ray. I'll show you one. So you diagnose by getting a stool PCR and toxin antigen testing. So this is how it looks like. Can you see the pseudomembrane here? I'm going to punch it here for you. So look at these arrows. You can see these yellow pseudomembranes. I'll show you another picture of it also, uh, an endoscopic picture here. So look, can you see, can you appreciate this pseudomembrane here? This yellow plate. This is something we get in C. difficile. All right. You diagnose by getting a stool PCR and toxin antigen testing. Toxic megacolon happens because there's severe inflammation and the colon massively dilates. There's a perforation risk also, and honestly, death is also possible, so it can become a medical emergency. You treat by giving an oral vancomycin. Here, this is the treatment. You give an oral vancomycin, or you can even give a fidomyxin. This is also an antibiotic. In recurrent cases, we give a fecal microbiota transplant. So sounds really weird, but basically we take the healthy stool flora from a healthy patient and transplant it into this patient. And that really helps you fight off the C. difficile. I'll stop the video here because it's getting too long, but I hope you guys got a good heads up on this.